So thank you very much, because we know that it is on the same time and it's in summer and it isn't so easy to be connected right now. We are really glad that you are able to explain your experience and how you discovered this syndrome. And Giacomo was the one that presented the syndrome to us a few months ago. And we have discovered new patients in the last months. So yeah, we really want to know about the disease, and perhaps you can introduce us. How did you manage with this syndrome? Thank you very much for joining us today.
So it's really a pleasure to be here. I wanted to give a very general background, and so I'll try to be both brief and general so that I don't overlap too much with the other speakers, and that we will leave time at the end where we can drill down more deeply on things that are of interest to people. So I'm going to back all the way up. The collagens are a superfamily of extracellular matrix proteins, and what their distinguishing feature is that they have a repeat of glycine XY, GlyXY, and this repeat over and over allows them to make this special structure, this triple helix. And there's 28 kinds of collagens. They were numbered sequentially as they were discovered. And so although we're talking about type 4 collagens, in fact, the type 4 collagens are the ancestral member of this superfamily. And the type 4 collagens are about 750 million years old, and they're present in every organism, in every tissue in the animal kingdom. So the type 4 collagens originally evolved as collagen 4 alpha 1 and collagen 4 alpha 2. These are again, the ancestral members. There was then a duplication of this part of the genome that gives collagen 4 alpha 3 and collagen 4 alpha 4, and then another duplication event later that gives collagen 4 alpha 5 and collagen 4 alpha 6. In common, they all are encoded into a protein that has this structure you can see at the amino terminus is a 7S domain. Most of the protein is this triple helix forming domain. It's a repeat of glycine XY, GlyXY. And then at the carboxy terminus is this NC1 or non-collagenous 1 domain. And the significance of these domains, the NC1 domain is responsible for recognizing its binding partner. So although you have these 6 different collagen alpha chains, they only ever form into 3 different heterotrimers. And that NC1 domain is critical for identifying the binding partners. So on the very top, you see the heterotrimer of alpha 1, alpha 1, alpha 2. So for example, collagen 4 alpha 2's NC1 domain recognizes 2 collagen 4 alpha 1 proteins, and then they wind up sort of like a braiding of a rope, the whole length of this triple helix forming domain. And you need glycine at every 3rd amino acid because that allows it to fold properly. And so the other 2 kinds of heterotrimers are collagen 4 alpha 3, 4, 5 and 5, 5, 6. And so it's been known, I consider them, it's helpful to think of Alport syndrome and the Gould syndrome, or COL4A1 and COL4A2 mutations, as sort of sister diseases. Alport syndrome's been known for much longer, and it tends to affect primarily the kidney because the 3-4-5 network replaces the 1-1-2 network in the glomerular basement membrane. But mutations, pathogenic variants of collagen 4 alpha 1 and collagen 4 alpha 2, we now know can cause pathology in almost every organ. And so again, you may wonder if collagen 4 alpha 1 and collagen 4 alpha 2 are so fundamental and they're in every organ, what took so long? Alport syndrome, as you can see, was first published in 1990, and the first reports that we had of collagen 4 alpha 1 causing disease in patients wasn't until 2005. And I think the biggest reasons for this are that mutations in collagen 4 alpha 1 and collagen 4 alpha 2 often cause congenital, so very early onset and relatively severe disease. And so you don't get these large pedigrees that allow you to sort of map the gene, which is how mutations for Alport syndrome were identified. but it's also this multi-systemic and clinically heterogeneous disease. So individuals may have very differing pathologies and different organs affected. I always like to give the example, you could have a physician with 20 people in their waiting room that all have a COL4A1 variant, but you might not imagine that they're related at all. And so because this is an eye-focused seminar in some ways, I thought I would share this, that although, you know, the cerebrovasculature has really stolen a lot of the thunder because of its importance with patients, the way that we initially identified these mutations was in a mutagenesis screen using mice because of this ocular anterior segment dysgenesis phenotype. As a postdoctoral fellow, I was actually very interested in Axenfeld-Rieger's syndrome, and we were studying FOXC1, some of you will be familiar with. And I was at the Jackson lab. Somebody came down the hall and said, we've got a mouse with this abnormal eye. Do you want to try and figure out what the gene is? Identified variants in collagen for alpha-1, and then set us down this path of really digging into a lot of the other phenotypes and organs. And so it does have this beginning in the eye, but I think that the eye serves also an important part of the present and in the future. So in the present, for example, retinal vascular tortuosity can be a pretty sensitive way to identify individuals who may have pathogenic variants, and monitoring intraocular pressure and controlling intraocular pressure is really one of the actionable things, one of very few actionable things that can be done for patients. So I think that that's the present, and in the future, you know, many of us are working on gene therapy approaches, and I think that targeting the eye and the corneal endothelium, for example, could be an early way for these gene therapies to be implemented in humans and sort of de-risked for more systemic use. And yeah, so I guess I mentioned what I think that how the eye is going to play a role in the present and the future, and then I will turn it back to the moderators for to hear from the rest of the speakers. So thank you very much.
Great, thanks, Douglas, for this explanation and very nice presentation of COL4A1. And so next speaker will be Dr. Stephanie Gay from Hôpital Lariboisière, Paris, France. Thank you very much to accept to be a participant of this webinar. And she will present the phenotypic spectrum of COL4A1A2, a cerebrovascular perspective.
Thank you very much for the introduction and for the invitation to this joint webinar. I'm from Lariboisière, indeed, from the French Reference Center for Rare Vascular Diseases of the Brain and the Eye, including COL4A1A2 angiopathies, among others. And today I will describe the phenotypic spectrum on the cerebrovascular window. First of all, I would like to highlight that COL4A1 and COL4A2 mutations are involved in two kinds of diseases that are highly different. On one hand, we have pathology that is related to pathogenic variant of COL4A1 or COL4A2 in the coding regions of the genes that lead to the impairment of the secretion or alteration of the trimer integrity in the extracellular matrix. This disease is caused by highly stereotyped tumor missense mutations that involve highly conserved glycine of the genes or stop codons that lead to haploinsufficiency. And this disease that described Douglas is a very heterogeneous, lead to a very heterogeneous phenotype with a multi-organ involvement of the brain, the eye, the kidney, muscle, systemic artery, and so on. Is characterized by a very variable age at onset from fetus to adult, a very incomplete penetrance, and from a cerebrovascular point of view, hemorrhagic stroke are far more frequent than ischemic stroke in this condition. And on the other side, we have newly discovered pathogenic variants in non-coding but regulatory regions of COL4A1 that lead to an overexpression of COL4A1 and that lead to a totally different disease that only affect adults, middle-aged adults, only affect the brain cerebrovasculature with only ischemic stroke, no hemorrhagic stroke, and high penetrance. And today, I will focus exclusively on the first of these conditions that involve both ophthalmologists and neurologists, both involved in adult and children care. As Douglas previously said, the spectrum is wide, with is a summary of the main targeted organ in COL4A1, COL4A2 glycine and stop codon variants. And some of these manifestations are related to vascular impairment, especially in the brain and the eyes. Indeed, COL4 is A1, A2 is a crucial component for basement membranes, including vascular basement membranes. And you can see here in this publication from Douglas that the basement membrane in mutated mice is as highly is abnormal with irregularities and disruption and herniation. And this alteration, it's schematic, but this alteration of the vascular wall lead to fragility of the vascular wall, and then rupture and susceptibility to hemorrhages. So the hemorrhages may occur, the hemorrhages are a main feature of this condition, and they may occur in the perinatal and fetal periods with different circumstances of discovery. Sometimes when hemorrhage occur before the birth, sometimes with a prenatal detection during obstetrical follow-up. Unfortunately, sometimes it is diagnosed because of an intrauterine fetal death or perinatal neurological distress. But sometimes it may be diagnosed later in the children with the development of an infantile hemiplegia, psychomotor delay, and epilepsy. And it's important to note that COL4A1, COL4A2 screening in context of fetal or perinatal intracerebral hemorrhage is always discussed after exclusion of common causes of intracranial hemorrhage during fetal and perinatal period, such as feto-maternal alloimmunization, since it may explain around near of 20% of fetal intracerebral hemorrhage in the recent series. Most often, the hemorrhage is diagnosed at the stage at a late stage when the parenchymal sequels are also developed, and grossly, the brain damages that result from these hemorrhages are both related to the severity of the bleeding, but also to the timing of occurrence of hemorrhage. And grossly, when the brain hemorrhage occurs during the late pregnancy or the perinatal period, children develop a porencephaly, which is a cystic cavity filled of cerebrospinal fluid directly connected with the ventricle. When the brain hemorrhage occurs early during the pregnancy, other severe malformative conditions may develop, such as schizencephaly, which consists in a cleft connecting the ventricle with the surface of the brain, or even hydranencephaly, which is quasi-complete destruction of the cerebral hemisphere when the hemorrhage occur very early during the pregnancy. But sometimes when the fetal or perinatal hemorrhage is very limited in size, the event can remain clinically silent, and patients will develop small porencephalic cysts, like you can see here, sometimes very subtle and limited to ventricular asymmetry, that can be discovered incidentally later in life. In some cases, the acute hemorrhage, perinatal acute hemorrhage, may be discovered in the acute phase, especially during the perinatal period, especially when after a vaginal delivery, because of the mechanical stress induced by this mode of delivery. And you have here an example of a patient, a young baby that developed an epilepsy at 3 days of life, with an acute hemorrhage in the left hemisphere, which will turn into a porencephalic cavity later in life in association with a psychomotor delay. ICH, intracranial hemorrhage, are also a main feature in adults, which carries mutation. And in adults, hemorrhage may occur at any age, even in young patients without any cerebrovascular risk factor. They are usually located in a deep region of the brain, either the deep brain nuclei, either the deep, the subcortical white matter or the deep white matter. And in some cases, they may be multifocal. In a fraction of patients, they may recur during the life, and they may be spontaneous, but also triggered by traumatism, sometimes very minor head trauma, sometimes after an unusual physical effort, sometimes in the occasion of an anticoagulant therapy. And often, but not always, the patients show other MRI marker of small vessel disease, but it's not always the case. Ischemic stroke are also a manifestation of COL4A1 A2 angiopathies. It's less frequent than brain ICH. Here again, it may occur at any age, including young patients, as is this patient that became hemiparetic because of this deep infarction. It is a usually deep infarct because of the involvement of penetrating arterioles, probably. And here again, very often associated with other small vessel disease markers, especially white matter hyperintensity that I will develop. Sometimes it's not the usual case, but sometimes patients may begin the disease with a brain infarction. It's the case of this patient that was asymptomatic before his 32 years, and that developed a transient hemiparesis in relation with this small deep infarct. And in this occasion, the brain MRI revealed extensive white matter hyperintensity, some few microbleeds, microhemorrhagic sequels, and very importantly, and it was a clue for COL4 testing in this patient, a silent porencephalic cyst near to the ventricle. And he is mutated in the COL4 with a glycine mutation. Which are the other imaging markers of small vessel disease? But very frequently, we may encounter white matter T2 hyperintensities. As you may see here, they are really frequent in the most of 50% of patients, but not always present. It may be observed at any age, even during childhood. But grossly, the prevalence and the extent of this lesion increase with age, as it is figured here. You may see that the extent is more marked for patients that are aged. they typically involve periventricular regions at the beginning and progressively extend in direction to the subcortical white matter. Other frequent markers are silent bleeding, microbleeds, like these dots, these black dots that you may see here, or silent macrobleeds, macro hemorrhage, as you can see here. And quite regularly, we find this kind of hole in the brain that are not small infarct, but dilated perivascular spaces, especially in the deep gray nuclei. Large or medium-sized artery may be involved in COL4A1, A2 angiopathy, especially with the development of intracranial aneurysms that very frequently involve the terminal carotid arteries. Quite usually are multiple, as you may see here, and sometimes bilateral. Very frequently, it's a silent lesion, but there is a risk of rupture depending on the size, of the shape of the aneurysm, and it exists as well a risk of compression of adjacent structures such as cranial nerve. So it is useful because actionable for the treatment to follow up the patient to detect these aneurysms. So this slide summarizes the circumstances that should lead to suspect COL4A1, A2 angiopathy in adult and in general. The occurrence of young onset intracranial hemorrhage, especially in the absence of a cardiovascular risk factor, obviously after exclusion of other common causes of hemorrhage, such as vascular malformation. A suggestive family history, such as history of unexplained ICH in the family or infantile hemiparesis in the family. So it is really important to grab the family history in this patient. Some radiological features are really a clue for helpful to suspect the diagnosis, and it is the case for the polyencephalic cyst. And of course, the general context with the search for involvement of other target organ is really important. Okay, just a last slide to show you, to illustrate the incomplete penetrance of this affection. Here is an example of a family which carry a typical mutation of COL4A1. And you may see that because of the incomplete penetrance, it is not unusual to observe generation skipping in the families. Here, the mother is totally asymptomatic, the MRI is normal. But he had a daughter which who is severely affected by an infantile hemiparesis associated to polyencephaly, and her brother had developed around 40 severe ICH responsible for an hemiplegia, in addition to renal insufficiency. So you may observe how the spectrum of severity and how is variable among individuals, even a given family, and how the penetrance is incomplete in this condition. Thank you.
Thank you very much. Wonderful images, I have to say, and scary ones. Our next speaker will be Professor Simona Balestrini. It seems that she travels a lot because she's a consultant pediatric neurologist at the Major Children's Hospital, but she's also the group leader at the Queen Square Institute of Neurology in London. And you have a research line on rare cerebrovascular syndrome, so I think that we will be grateful to hear you talk about the epilepsy. Thank you very much for accepting the participation.
Thank you.
Thanks for the kind introduction and for the invitation to this very interesting and important webinar. So I have the hard task to summarize the epilepsy feature of COL4A1 and COL4A2 condition in 15 minutes. I'll try my best. I thought to start from the most common brain structural abnormality, but Professor Gibb did an excellent job, so that I will go quite fast on that, and then we'll focus more on the most typical epilepsy feature and how we can manage epilepsy in these patients. So I think it's important to start from this simple diagram, which is from the latest classification of epilepsy, which is actually relatively simple now, because usually we have to establish whether people have focal onset seizure or generalized onset seizure. That's very important for us in terms of management, in terms of choice of treatment, and sometimes also to consider surgery. But what is becoming more and more important in our management of people with epilepsy is the etiology. We had to try to identify the etiology because this has even more important implication in terms of management. And with COL4A1 and COL4A2, we cover both these etiological categories because we have mutation in these genes that in most cases lead to structural abnormalities. And these often then lead to generation of seizures. So I think I don't really need to go into detail about these, but I thought it was important to go through the most important studies that really allow us to know what this mutation can cause. And this is also important to summarize what are the structural abnormalities we most often find in these patients. So this is the seminal paper by Professor Good, who described for the first time this mutation and put the mutation in association with porencephaly, and this was later confirmed also for the COL4A2 gene. Then we again had the work from Professor Good about the association of COL4A1 mutation with small vessel disease, which can be another imaging phenotype, as we just saw, and again can be associated with epilepsy phenotypes. We then have even more rare conditions, such as Hannak syndrome, where COL4A1 pathogenic variant can lead to a syndrome characterized by angiopathy, nephropathy, aneurysm. Most often we have aneurysm affecting the carotid arteries or cerebral artery, and there is almost often, again, evidence of small vessel disease and damage to the white matter. We then have even this more rare syndrome that we also saw earlier. This is related to one single mutation in a non-coding region of the COL4A1 gene, and this leads to a quite specific phenotype where we see these lacunar infarcts in the pons, but we again see quite widespread damage to the white matter. So a leukoencephalopathy phenotype, which, as we saw earlier very nicely, can vary in terms of severity, in terms of extension, but is a quite constant feature in our patient. And even more recent, we saw the confirmation of genetic variant in COL4A1 and COL4A2 as a risk factor for intracerebral hemorrhage. And this, again, of course, can lead to abnormal brain feature and in turn can lead to epilepsy more often in adult patients. And finally, but not least important, especially when we now have to discuss epilepsy, is the spectrum of cortical malformation. Again, we earlier saw this, but this is very important because the susceptibility of the fragility of brain vessels in the prenatal period definitely may lead to malformation of cortical development. And we saw that these can be some examples. So we see schizencephaly at the top. We can see the association also with heterotopia, periventricular heterotopia. And this can be also associated, sometimes also polymacrogyria. These again represent a spectrum of malformation that can be associated to quite severe epilepsy with early onset. And starting from this point of this very wide spectrum of imaging abnormality that we can find in our patient, we conducted this study that was published last year, where we basically analyze all patients reported in the literature and also a new original cohort from our patient that are under follow-up at our center here in Florence. And we try to get information on the various neurological manifestations, but also extra neurological. Of course, now we need to focus on the neurological. And we found a variable prevalence of epilepsy, so ranging from 20% with COL4A1 to 30% with COL4A1 variant. And when we wanted to characterize the epilepsy, in the majority we found focal onset seizure, but we also found epileptic spasm, usually with earlier onset, so even within the first year of life, but also a minority, around 5% of the cohort, of the total cohort, a generalized onset seizure. Of course, from the literature review that was quite large, we could not really find detail of the epilepsy. The majority of patients had childhood onset epilepsy, but we also had a minority with adult onset epilepsy. So we cannot really never exclude COL4A1, COL4A2 etiology, even when we have an adult onset epilepsy. And this was one of our other works that was actually is a bit older, but here we described an original cohort again of patients, and our specific aim was to characterize the neurological phenotype, and we found pretty similar results. Of course, there was the bias of selection of neurological phenotype, so we found epilepsy in the majority of patients here, 38 out of 44, but again, we found this wide spectrum. So the spectrum is not wide only in terms of abnormalities, but also in terms of type of seizure. And so focal onset seizure are the most frequent, but again, we can see epileptic spasm and generalized seizure without an obvious focal onset. Here, the mean age at onset was a bit earlier, was around 15 months. And what is interesting is that in a subset of patients, epilepsy was the initial clinical presentation in the absence of other feature at the onset. And also, when we went a bit more into detail regarding the seizure phenotype, we confirmed that the onset was focal based on the semiology and, of course, of the ICTAR findings. But some patients had the multifocal changes, so it was not all coming from just an area of the brain. Also, we had almost 40% of patients that had more severe seizure presentations, such as status epilepticus or prolonged seizures. So these are real emergency requiring hospitalization, requiring emergency treatment. And also, what I would like to highlight here is that the majority of our patients with focal seizure and also very widespread abnormalities on the EEG, and these often correlated with widespread abnormality on neuroimaging, and these most often are alteration of the white matter, so the leukoencephalopathy pattern that we saw from the imaging studies. And this suggests, it's very important because it suggests in terms of pathophysiological mechanisms that although we have often kind of focal abnormalities, this sort of underlying sufferance of the brain vessel leading to the leukoencephality is more widespread. And often this cohort had also comorbidities, including intellectual disability and motor impairment. Again, we had this wide spectrum of imaging abnormalities, including, again, leukoencephaly, but also malformation of cortical development, such as sporencephaly. Here you can see, I'm not sure you can see my arrow though, and schizencephaly. We did not find a genotype-phenotype correlation, so we don't really see an association in terms of type of mutation or location of the mutation in the two genes with the specific phenotype or with a more severe or less severe phenotype. But we did observe a generational gradient of disease severity. This is important. So in a few families, unfortunately, the diagnosis was made only when there was a problem with the most severe phenotype, so an epileptic encephalopathy with very severe epilepsy. Going backward, we had mildly affected members or even just asymptomatic members that were carrier of the variant, but they were not just diagnosed because probably the phenotype was not severe enough. This is our most recent work where also we included a subset of patients. These were all people with onset of seizure in childhood. Again, we confirmed this spectrum of seizure types, and this also spectrum of different abnormalities on the EEG, including also more widespread abnormalities. The few final slides will be on management of epilepsy. I wanted to cite this work from Chinese colleagues. They reported 5 patients with West syndrome. West syndrome is an epileptic encephalopathy with onset in early childhood. This is quite variable in terms of etiology, but of course in these 5 cases, the etiology was COL4A1 and COL4A2 mutation. They all had sufferance, they all had the leukoencephalopathy pattern on the imaging, and they were all drug resistant. But one patient was reported to then have become seizure-free after functional hemispherectomy, so surgical treatment with a sort of disconnection between the 2 hemispheres. And expanding on this, we had additional report, both from our work, but also from other reports in the literature, where other surgical approaches were used successfully, including callosotomy, functional hemispherectomy in another case, and also resection of enfocal cortical dysplasia, all with successful seizure outcome. The most recent work on epilepsy surgery in this patient is this one, published again from Chinese colleagues this year, where they included 8 patients who underwent a unilateral posterior. So here they only disconnected the posterior cerebral area, and 5 out of 6 patients were seizure-free for at least 11 months without surgical complication. They all had focal cortical dysplasia as the underlying histology. So in summary, for management, while for pharmacological treatment, we do not really have any evidence to say one drug is better than another. We cannot say that. So we need to still treat our patient on an empirical base. We choose our treatment based on the clinical semiology of the seizure and the EEG findings. Unfortunately, most of our patients remain drug resistant. This is also confirmed by the literature. On the positive side, we can consider surgery because, first of all, there is no of course, these are still few cases, so it is anecdotal evidence, it's not robust evidence, but it's good to note that there is no evidence for increased risk of bleeding for surgery. And so if surgery is appropriate on a clinical ground, then we should consider this option as an additional option. So my main sort of take-home message include the fact that we always need to consider this diagnosis because sometimes we have milder cases, for example, with seizure as an initial clinical presentation, sometimes also with adult onset. But if there are underlying imaging abnormalities, often mimicking traumatic injury or hypoxic ischemic injury or intrauterine infection, we also need to consider COL4A1, COL4A2 as differential. There is often other organ involvement. We need always to screen for other organ involvement because in the majority, for example, of our original cohorts, we always had some other organ involvement in our people with epilepsy. The most typical presentation are focal onset seizure or epileptic spasm when it's earlier onset. They can be associated to the wide spectrum of malformation or cortical abnormality, but the association between anatomical features and EEG and semiology is not always straightforward because we have a quite complex pattern of damage. So in summary, I would suggest that when we have an unexplained epilepsy with some type of brain structural abnormality that we can fit with the COL4A1, COL4A2 disorder, and especially if there are also other organ involvement, especially, of course, ophthalmological abnormality that we will hear about in a minute, but also nephrological abnormality and so on, then we should consider this diagnosis because as implication, of course, for counseling, for prognosis, and for management. Thank you.
Thank you very much, Simona, for those informations, very relevant. And thank you for both last speakers for the very nice brain imaging. And I'm sure all will have useful information with those. So I'm very happy to introduce now Dr. Giacomo Bacci from AOU Meyer Consortium from Florence, Italy. He is they are a full member of European Reference Network, ERNI. And so thanks a lot for For this, Giacomo, the floor is yours.
Thank you very much. I want to briefly look in what an ophthalmology can help all the team. As you can see, the disease related to COL4A1 and 2 is extremely complex. So I'll briefly explain what are the ophthalmological features. These are my disclosures. And someone of you probably see this presentation before because it all started to what we noticed about the ocular clinical pictures in this rare disease and complex patients to be examined because they have main neurological problems, so it is very difficult to see them. And today it is actually already too little known clinical entities, and I will bring you the experience we collect from a case series. I will skip this slide because you saw that COL4A1 and 42 are related to alpha subunit of collagen type 4, and today there are many papers that explained the pathogenic mechanism. And the eyes actually, it is well known that the impaired retinal vascular outgrowth and patterning is actually related to the TGF-beta pathways activations. And for ophthalmologists and not ophthalmologists, actually, the first question is why the eye should be so largely involved, and why especially the anterior part of the eye should be involved. This old paper in 2009 can show you that in mice, the presence of COL4A1 42 is actually present in the lens capsule, in the internal limiting membrane, in the hyaloid vessels, and also in the RP and the chorocapillaris. And if you see this oldest paper, you see that also in the human eye, there are large expression of the collagen type 4 in the trabecular meshwork, in the lens capsule, in the optic nerve, in the blood vessels, and in other parts of the eye as well. So it is now know that the COL4A1A2 is a manifestation because the eye is organ rich of collagen type 4. And if you look at the associated phenotypes, today you find on OMIN that the main findings is the retinal artery tortuosity related to COL4A1A2 and or the RATOR. But actually, we'll see in a minute that the clinical picture can be more complex than that. And there are a large number of papers that describe the association of COL4A1A2 related disorders with some kind of congenital cataracts, microphthalmia, microcornea, as well in the hyaluronic dysgenesis, iris hypoplasia, Axenfeld-Rieger anomalies. This is a rare manifestation, but frequently reported in literature. So the aim of our study was actually to evaluate the multi-organ involvement and to see if we can make a standardized approach for the screening and the clinical management for prevention and complication you saw that are actually really severe, especially from the neurological part. And so we start with a systematic review, as Simona said, with a questionnaire to the patients, and we get deep in detail in oligosymptomatic and unsymptomatic carriers for the ophthalmological and also cardiological evaluation, just to see if we can collect a clinical management protocol. I say that the literature is increasing papers on the manifestations, and the most intriguing part is that congenital cataracts is actually part of, not a negligible part of the spectrum. There are some colleagues that tells you that some kids with congenital cataract can actually experience a stroke during the surgery without knowing that there is a COL4A1A2 manifestation. And so what we wondered about, we wondered if we can find subclinical manifestations in apparently healthy carrier to focus on our attentions as ophthalmologists and to improve the diagnostic health for these patients. And so we collected the standard methods for an ophthalmology evaluation with an anterior segment imaging and posterior segment imaging in healthy carriers. And we saw very tiny and negligible abnormalities but they can be very important if you are looking for a patient affected by this disease. As you can see, this little cataract on one eye, probably you do not post much attention. We saw also anterior segment with evaluation of the irid, the angle of the eye, and the OCT helped us a lot. And I'll show you. I talked mainly to the ophthalmologist because this is the typical appearance of what are named the retinal artery tortuosity. You see these swelling vessels at the posterior pole that are usually we do not pose so much attention, but we have to if we have the suspect of such patients. And also you can find these carriers minor abnormalities such an iridocorneal dysgenesis that you can see ophthalmoscopically, but also you can see with an anterior segment OCT. But again, if they do not experience glaucoma, probably you do not pose so much attention to this. And this is our casuistic. As you can see, the all carriers carried a good visual acuity in both eyes. The retinal vessel tortuosity was not a measured feature. Some of them presented it, but not all. And the presentation was mainly for COL4A1, that is more frequent than COL4A2. And these findings are actually consistent to what we find in the literature. And if we compare our cohort with the systematic review, we can see that the clinical presentation is actually the same of the review of the described patients in literature, both for COL4A1 and COL4A2. And the conclusion is actually that the ophthalmology should be absolutely part of the evaluation of these patients, because it is this disease as a pleiotropic nature, but actually there are some anatomical areas that actually can be influenced by this complex gene. No definitive genotype phenotype. We cannot help this genotype phenotype relationship, but we can say that the COL4A2 are actually related to a milder phenotype. As ophthalmologists, we talk about red flags. We cannot be so much of help in the prenatal period for these patients, but in the postnatal periods, absolutely yes. If we find the congenital cataracts, maybe with some, if we see this fundus, the retinal artery tortuosity together with an anterior segment dysgenesis, we have to pose attentions and talk with the other specialists to see if it is a patient at risk to have this disorder. And these are the two patients we published recently. We basically defined that the baseline, the funduscomic and the slit lamp examination is actually the first things, and when possible an OCT to see if actually, especially if a glaucoma is present, is necessary to have a longitudinal evaluation, and as a neuro-ophthalmologist, a prompt CBI diagnosis and for the treatment planning is necessary. In conclusion, as you can see, the ocular involvement is actually frequently involved in ophthalmology, and the ocular manifestations are actually poorly specific if you can find it isolated, but can be a very powerful diagnostic tool if combined. If you have a carrier phenotype, maybe you can help as ophthalmologists to validate a variant of unknown significance. So you can close a diagnosis for the team, and it is difficult for us as ophthalmology to take a careful family history, but when we have a patients possibly affected by COL4A1, A2, go deep in detail in the family history, and the parents' phenotype can be of extremely help. And obviously the severity of clinical presentation should guide the dedicated follow-up. This is the last slide. I strongly wanted to be part of this webinar, and I thank all the participants, because the awareness of the ocular manifestation of this disorder is actually critical. I think for target the clinical suspect to increase the detection rate of the disease, and as a consequence to reduce the burden of serious complication with an early diagnosis. I reckon that there is a significant amount of work to be done. As ophthalmologists, you can say what kind of congenital cataract should be raised the suspect of COL4A1, A2. I cannot give you a response now. So we have to go deep in the understanding of the ocular manifestation to provide to all ophthalmologists that are possibly carrying these patients the most detailed information to help the team at the best and change the life of these patients. Please let me briefly thank all my team here in Florence. Let me thank the Associazione Famiglie COL4A1, A2 that involved me in this, and all my colleagues that wanted to participate to this webinar today. Thank you very much.
Thank you very much. We are honored by your presence, Dr. Gold. I have to say thank you from the other side of the ocean. And I will, hopefully, we will have more meetings. I think that it was really interesting to share our experience with the pediatric neurologist. So hopefully we will have more options in the future to talk about all the diseases. Thank you very much. And thank you to all the people that was connected this afternoon. See you soon, I hope.